I'm Dr. Mila Brujic, and I'm joined with Dr. Maria Walker talking about why things get so foggy on the OI show. So, Maria, welcome back. One of my favorite things to talk about here is to really pick the brains of the leaders in the profession, and certainly you are one of them. And you actually have some new updates to share with us with your lab. So please, Maria, share your new updates.
Yeah, sure. So one of the main things that we look at in my lab, I look at all kinds of scleral complications, but anyone who's heard me speak probably knows I have a special place in my heart for those patients who experience midday fogging. So I've looked, and I think the last time I talked a lot about the lipids that we found. So we've looked at the lipids, we've looked at the proteins, and now we've actually looked at cells as well. And so probably the most exciting new findings that we have is that we've confirmed, there was actually a study in 2019 that looked and found that there was neutrophils in the fluid reservoir, so that gets trapped there. So neutrophils are, as you know, the most abundant immune cell really in the body.
Maria, so just to break that down a little bit. So you're looking at scleral lens wearers that are those foggers. And again, we know we had those foggers, we have those non-foggers. So you're looking at the ones where that fluid is physically foggy, and we see that on OCT, we see that at slit lamp. And now you're analyzing those patients and asking what's different about these people, correct?
Yes, exactly. So we have patients who don't have fogging, because you always want to have some sort of control so you can see if it's not there. And if you look at those and compare those to the patients with fogging, that's what we do. So I think last time we talked about the lipids. And so we found that the balance of basically there's a lot of free fatty acid lipid types of things. So things that are very hydrophobic. And we also found specifically that the ratio, and this was something I don't think we had known last time, the ratio of unsaturated to saturated lipids is actually increased. And so that was a super interesting finding, because one thing that you definitely know, and I know from clinic, is that we tend to see it more in our dry eye patients. And so if you look at dry eye patients, they have a very similar sort of dysfunction of their lipids, and the ratio of those that are saturated and those that are unsaturated are different. And if you kind of remember to biology, right? We know that some lipids are solid at room temperature. So it's those ones, like the buttery lipids, not the oily lipids, that are more prevalent in the midday fogging. So that was lipids. So that was number one.
So wait a second, Maria. So abnormalities that we're seeing in the dry eye patient, you're actually seeing those similar ratios of lipids in the foggers.
Exactly. And they're coming from the meibomian glands. And so we know that many of our patients, especially the ones with meibomian gland dysfunction, I think clinically, those are the ones to look out for, because those are the ones that have abnormal lipids. So you can almost predict that they're going to have more midday fogging based on that.
Okay, good.
Yeah. So the new stuff, so then we also looked at proteins, didn't really find any changes in the proteins, which was interesting, because one of the things that I've talked to you about before is these mucins, right? So mucins are they're glycoproteins, right? So they're a type of protein with a carbohydrate attached. But those, we've looked specifically, and we looked again in this study, didn't find any changes in the mucins. And so again, evidence that myth, which I understand how that kind of got perpetuated, it makes sense. But mucins are actually very hydrophilic or water loving. So I really don't think that that's happening in any of the midday fogging cases. So that, I think, was an important kind of pertinent negative that we found. So the other thing that I mentioned was looking at the actual cells. So we take the fluid from that bowl of the scleral lens as they're taking it out, and we just drop the fluid, the tear fluid, the reservoir, onto a microscope slide. We let it dry. We compare the fogging to the non-fogging. And you use a very simple dye. It's called an H&E stain. Any first-year biology student has probably used it in lab. And it'll stain the nuclei and the cells itself. And what we found was you could very clearly see hundreds and hundrds of neutrophils in these fluid samples from midday fogging, but you can tell it's a neutrophil because they have a very distinct shape. And then we found almost none. There was a few in the non-fogging eyes. The other thing that we did find was also epithelial cells. So that's another thing that people say might be in there. And we confirmed that, yes, we think that there's epithelial cells in there as well, but not nearly as many compared to the number of neutrophils in those samples.
So non-foggers, they have more normal ratios of lipids versus the foggers.
Correct.
Non-foggers have way less neutrophils than foggers, and you're not seeing any epithelial cells in the non-foggers, and in the foggers, you're actually seeing some epithelial cells.
Right.
And are they total epithelial cells or conjunctival, or can you even tell from?
They're epithelial. They're likely to be corneal epithelial. They look very much like corneal epithelial, and some of them have kind of the elongated shape that you would expect the cells on the surface, which are going to be sloughed off anyways, to have.
Okay.
And an interesting point to make there as well is neutrophils. There's a lot of work now, or maybe not a lot, I'm biased, but there's definitely work now being done at looking at neutrophils in tears overnight. So we actually know that neutrophils come out into the tears as we're sleeping. So again, you also have that anecdotal clinical evidence of I tell my patients, wait 10, 20 minutes after you wake up before you even think about putting on the lenses. Or we give them a couple drops of saline, like a gentle eye wash. And what that is doing, I think, is removing those overnight neutrophils, which are just going to contribute to that fogging once they put the lens on and trap it on there.
So Maria, as a leader in the profession, I have to ask you, because clinically, I mean, we see these people and we try and kind of go through a process of elimination on how we're going to eliminate or reduce that fogging. Sometimes you can't eliminate it, but most of the times you can at least reduce it. What are you foreseeing as our strategies to help mitigate that so that we're not seeing inflammation in the bowls of the lenses?
Yeah, so I think, starting conservatively, just kind of lifestyle changes for patients. One, we always say this, treat the meibomian gland disease, treat the dry. I know a lot of times they're being used as part of a treatment, but try to get as much of that debris and as much of that kind of gunky meibomian gland fluid off the eye, because the more that's on there and that's in the tears, the more it's going to get trapped on. So for some patients, just a gentle eye wash will kind of work. But, the space that I'm working in now is looking at what some of the therapeutics might be able to do for us, because there's a lot of therapeutics that are used for off label, right? You've got mast cell stabilizers, for example, is one that we're looking at, because mast cells contribute to neutrophil recruitment. So I have a couple of patients kind of testing it out for me. Of course, most of our mast cell stabilizers are preserved, so you don't want to put them in the bowl, but using them, also treating allergies. All of those anti-inflammatory medications are going to reduce the presence of all the stuff that's on the ocular surface that's going to recruit these neutrophils in the first place. And I think, using a tear fluid that more closely mimics, we've been saying this again and again, using fluid that is more biocompatible than just a standard saline solution. So we use things like preservative-free artificial tears and some of the preservative-free medications off label. I think it would be great to see some of those used more like in a clinical trial, so we can give more specific advice. But I always, I'll try different medications with patients, see if it improves. So I get improvement with like antihistamine type of allergy medications. Certainly some of the, I've got some patients who use autologous serum that seems to help. But yeah, we really need more real clinical studies that actually look objectively and see which ones help the most.
Yeah, so isolate the foggers and then have them as the trial group, and then utilize a group of patients who we know fog and expose them to treatments and everything, or expose them to treatment or no treatment.
Exactly.
It's interesting. So Maria, just out of curiosity, so this is just kind of a question that I have. So as a clinician, one, we can sometimes visibly see inflammation through hyperemia or redness on the eyes. One of the things that we can do objectively is we can actually measure matrix metalloproteinase 9 levels, or MMP9, from the inflammadry test. I mean, is that something that you kind of see plays a role maybe for the scleral lens wearer? Like check just
Yeah.
general levels, not necessarily in the bowl, but check them.
No, that's a great question. Yeah, so MMP9 is also something that recruits neutrophils. So yes, absolutely. And the MMP9 levels are very intercorrelated with all the different types of cytokines and proteins that encourage inflammation on the eye. That's why that's the one that we test for in that because that's the one that really goes up when a lot of the other inflammatory meters are going up on the eye. So yeah, absolutely. I do the inflammadry quite a bit, actually. And I couldn't say whether or not I see it more with midday fogging or not, but certainly it helps to kind of guide your treatment. If you're seeing somebody who's got midday fogging, you think they might be at risk, it doesn't hurt to do the inflammadry, and then you're going to know what the MMP9 levels are. You're going to know there's inflammation on the ocular surface, so you might be more driven to treat them with something that's going to reduce that. I stay away from steroids for the obvious reasons. That's the best one to use. But all these anti-inflammatory medications, there's so many safe anti-inflammatory eye drops that you can use and see if any of them help.
It is interesting. There are, we're in a plethora of new generation pharmaceuticals with Lotemax SM, Flarex, Isuvis, that it's remarkably, they only had about, I think it was 0.3% of patients that experience an intraocular pressure increase. So there is this category of safe steroids that may even have not necessarily a long-term role, but a temporary role with this. And it's interesting you say all this because, now I'm kind of thinking back on the patients that are the foggers, and you do see that they're the ones with the more reactive eyes, the cones that have the atopic disease, the severe dry eye patients where we're looking at a scleral shell where we have a handful of them where we're putting Regenerize, which is amniotic tissue fluid, in the bowl of the lens with the actual filling solution in the bowl of the lens prior to installation, just to attempt to remove some of that inflammation that we're seeing. So it's interesting that you're making that connection. And I think it's going to provide us with some, I feel, good clinical direction in the future. And you are a whirlwind of information, and it's mentally exhausting because you take us through. I've always loved understanding the basic science to help explain why we're seeing what we are in clinical practice, because that actually gives us good direction on how we may be able to reduce this in the future. So, Maria, thank you so much for joining us on another episode. We really, really appreciate you being here.
Thank you for having me. It's always a pleasure.
And thank you all for joining us on this episode of The OI Show.